introduction. I quickly realized last time I quickly ran out of time lah because I spoke too much. So inshallah today I have got a few bits to cover. So I'm gonna try and make it as brief but also as useful as possible lah. I'm gonna try and make it as interactive as well. So kalau people can chip in as we go along, that would be really good lah. Otherwise, just shoot your answers ataupun your questions in the text chat box, inshallah. Okay, so today, so for people who don't know me, my name is Naim Cik Rahimi. I'm one of the Haematology registrars from Royal Berkshire Hospital, ST3, so very, very young lah in the Haematology field. Okay, hopefully I've got something to share, inshallah. So last time we covered coagulation and anticoagulation. I hope I covered it extensively, but there were a few bits that I think some people have had questions about, like warfarin and how to dose, how to start anticoagulation and so on. Which if possible, we can talk about it at the end of this lecture lah. So today I'm planning to cover a bit about transfusion and blood products, and this is something that you would come across quite often, especially if you're in surgery, for example, or obstetrics, or even like general medical. And then I thought I would briefly go about common things that you come across as an F1 or indeed as a general medical or general doctor on the ward, including how to interpret blood tests. So common questions that we hematologists are asked about, especially regarding abnormalities of blood count, and then common diagnostic tests that you are asked by your consultants to send, like myeloma screen, for example, and iron studies. How do you go about interpreting your iron parameters? I'm sure this is covered in your medical school lah. Tapi it's good to have some sort of revision. Okay, so if we go straight to transfusion, sorry, these are the slides from last month. Okay, so transfusion. I thought the first thing I would cover is can everyone see the slide fully without, because I've got your face juga up here, tapi tak nampak kan your face when I present. Okay. Okay, so I thought I'd start with like terminology and like the basic of transfusion testing. Siapa yang tahu apa beza? So when what is the difference when you ask for group and save or group and screen versus cross matching? Siapa boleh tahu? Dia taklah important sangat sebab at the end of the day you get the same and product lah, you know what you want kan. Tapi when you speak to the lab, it's important to know what you're asking for lah, otherwise you're going to be waiting kan. So the way I was taught as an F1 or group and save tu, kalau if you want to test a patient's group and then you want to save it, and then cross match is when you want the blood right now, so that therefore you cross match kan. Which is somewhat true lah, but terminologically probably not as accurate lah. So there are two separate things, but when you cross match, if you want to cross match blood, you need to have a group and screen kan. People often use the term group and screen and group and save interchangeably, which is okay, but probably not as accurate. Sebab what you are doing is actually you are grouping a patient's blood group and you are screening for antibodies, okay? And to understand this, we just go back to the basics of your blood cell phenotype lah. So as you are all aware, every blood cells in your blood express certain phenotype, and then they express these groups lah. These antigens that can be grouped into group system. And this depends on your genetic makeup lah. So different people have got different expression kan. The most important and probably most well known is your ABO group, as you know kan. And the reason why it's it's the most important is because in the ABO group you either express A antigen, B antigen, both or neither kan. So you have your four blood groups. And what's unique about this group system compared to the other groups are that you are born with automatic immunity against the antigen that you don't have. So you don't need any prior exposure. You are born automatically. For example, if you are group A and therefore you only express A antigen, you automatically have antibodies against B. So you have anti-B and antigen A. And if you are born with antigen A and B, you don't have any antibodies. If you are born with without any antigens, you are born with both anti-A and anti-B kan. And the important thing about these antibodies is that they are IgM. Okay, and what's unique about IgM compared to other types of antibodies is IgM is pentameric kan. So it exists in five polymer, 5 monomers kan. And the reason why this is important is, first of all, pentameric antibody, so IgM doesn't cross the placenta. So it doesn't matter if there's a mismatch between the fetus. So if you're pregnant, so these antibodies will not cross the placenta and cause problems, number one. And number two, it's very, very dangerous if you are exposed to antigens that you're not supposed to expose yourself to. So this is ABO group mismatch kan. So if you give someone with blood group O, for example, you give them AB, and therefore you are exposing them to antigen A and B. So these antibodies will work against that, and because they are pentameric, they will quickly they can quickly form a red cell clump, and that can activate the complement cascade. And this is why patients so ABO mismatch is a never event, because it can activate this complement cascade and cause cytokine release. Patients become hypotensive, high oxygen requirement, and so on, and they can die lah, and they cause major DIC. So that's why it's very important. That's why ABO group is something that we want to look out for kan. The other group, so as well as the ABO group, you also have different blood groups. So you have the RH group. So this is something that people are aware of as well. So within the RH group, you have D. Either you have D or you don't have D. You have either big C or little c, big E, little e. And then on top of that, you also have these other less well-known groups. So your Cal, your Duffy, your MN, JK, semua lah. Okay, kenapa why I'm telling you about this is because, okay, the difference between these blood groups and the major ABO group is that you are not born with automatic antibodies against these groups that you don't have. For example, if you are D positive, if you are D negative, you are not born with antibodies against D. Okay, but you can develop antibodies following sensitization. Okay, what I mean by sensitization is if you are exposed to any blood products or any blood that contains D on top, if you are D negative. Okay, does that make sense? Okay, so this means that any prior transfusion will increase your risk of forming antibodies against these blood groups, these other groups. Okay, so transfusion. If you become pregnant, sometimes you can get exposed to your child, the fetus, because you can be exposed to fetal circulating blood that contains antigen that you don't have, and therefore you produce antibodies against them. Okay, okay. So these antibodies are IgG. Okay, what that means is it wouldn't cause the same effect as it wouldn't cause acute hemolytic reaction that you would get from ABO mismatch, tapi it will cause some hemolytic reaction. So for example, if you have antibodies, previously you had transfusion and you start developing antibodies against M, for example, and then you get another blood product that contains M, you can then destroy that additional blood that you are given. That's why we want to know if you produce antibodies. So number one, and number two, because the IgG antibodies can also cross the placenta. So if a pregnant lady has or developed antibodies from previous transfusion or pregnancy or whatever, and these antibodies cross the placenta, it can cause problems to the fetus, and sometimes you can get fetal hemolytic problem lah. Okay, and where the fetus the fetus becomes anemic and they develop hydrocephalus and so on. So that's a huge problem lah. So okay, coming back to this, so group and screen basically means you are grouping the blood. So you want to see what their ABO group is, and you also want to see what their D group is, because D is important. Because people tend to develop more, it has greater implications in pregnancy lah, basically, and also you tend to develop that there's a higher risk of developing antibodies against D compared to the other group. So that's the group bit, and the screen bit is screening for antibodies. Okay, it screens your plasma for any antibodies that you may have developed. Okay, and that's why so sometimes group and screen is very easy, because you don't have any antibodies, so you just get the group and then you can issue blood products right away. But in some other patients, especially patients who have had multiple transfusion before, can you think of any group of patients that falls into this risk category? Cancer patient kan, patient yang memang anemic, apa lagi, sickle cell patient kan. So these are the patients who have a higher risk of developing antibodies kan. So when you group and screen, so what you are actually doing, because you can't possibly screen for, you can't possibly group for every single antigen. So you can screen for antibodies, and then when your screen is positive, you have to then find out what antibodies are they? Are they antibodies against D, K, J, JK, for example, kan? So that's why kenapa I'm telling you guys about this is because when you ask the lab to do group and screen and they find an antibody, especially if you work in a DGH and not in a tertiary center, sometimes they will have to send this blood to the reference lab to be tested. So it will take sometimes 1 or 2 days for them to be able to get a full result. So that's why it's important to be aware. For example, if you want to give your patients blood, sometimes the lab wouldn't the lab people are not going to be able to give you the blood straight away without being able to tell you what exactly, because if you have antibodies against certain antigen, they would have to match to give you the proper blood products that match that specific antigen kan, or antibody that doesn't contain that specific antigen against the antibodies. So it's very important that you understand the indication of your patients needing blood. Okay. So because you have to weigh the benefit and the risk because sometimes you just have to give whatever blood that you have to stop the patient from dying kan. But if the patient does not need that blood there and then, we might be able to go some other way. Okay, dah panjang pula. Okay, so that's group and screen. And then cross-match is actually the process of, so once you've got the patient group and antibody, so cross-match is basically you take a sample of the blood product and you mix it with the patient and see if there's any reaction. So that's how people used to cross-match. But now, now with the demand that we have on our blood product, you normally just electronically cross-match lah. So you don't have to manually do so that's very historic lah. But that is basically what cross-matching means. Okay. Hopefully that clears things up lah. Okay, then what are the blood products that you have kan? I touched briefly on this in the last session. Tapi essentially, so your blood consists of red cells, a buffy coat which contains your white blood cell and platelets, and plasma. And plasma contains your protein. It contains your albumin. So most of the plasma is actually albumin, but it also contains all of your clotting factors. Okay. So when you donate blood, what the people in the NHSBT does or do, they will actually separate your blood into these different products. So it's separated into your packed red cell. And then since 1999, all of the blood products in the UK are leukodepleted, which means that they remove all of the, they can't remove everything, but they remove most of the white cells, which includes your T cells. And this significantly reduced the risk of immune reaction against your the blood product. That's why you see a lot less immune reaction against your against transfusion. So things like Charlie and like delayed immune reaction against the platelets and so on because of this leukodepletion. But there is still that risk because you cannot remove everything. And then they take, because there's only a little platelet in each group, in each of the blood that you give. So they will take bits of platelet from different people and pool it into one pool of platelets. Okay, that's why it's the difference between single donor units and pooled donor. So usually packed red cells, fresh frozen plasma is available as single unit, which means that it comes from a single donor lah. When you say pool, so pool of platelets, pool of cryoprecipitate, it means that it comes from different group of people lah. Okay, So these are just some terminology when we talk about different blood products. And so leukodepletion is when you remove all of the white cells, or you try to remove all of them. Single donor versus pooled donor. What is FFP versus octoplasma? I'm not sure if you guys have come across this. So FFP is basically your fresh frozen plasma, and it contains most of your clotting factors. So if you want to replace people's clotting factor, you can give FFP very easily. Octoplas is actually a different product. It's actually a brand name, kan? Tapi it's a different product which contains detergent solvent FFP. So it's actually so FFP is available as a single unit. Octoplas is available as a pool. So they pool plasma from different groups of people, and then they treat it with detergent. And the reason for doing that is because they want to reduce the risk of viral transmission, because these products are brought from like different countries. So it's slightly different, and it really depends on what your sort of hospital unit use lah. Cryoprecipitate is basically a concentrated version of your plasma, and it contains a concentrated portion of fibrinogen. And this is what we give for low fibrinogen, like hypofibrinogenemia. And then I'm sure you've come across irradiated blood products, CMV negative, HBS negative, and washed. So irradiated, do you guys know who gets irradiated blood products? Siapa yang work dekat hematology before? And the reason why we give irradiated blood products? Siapa nak? Any takers?
Is it people with bone marrow suppression?
Not necessarily. Specific bone marrow suppression. Okay, dia ada 3 kali. I'm not sure how the way your hospital do it lah. Tapi in my hospital, we prescribe blood products on EPR. And then when you type blood product tu, on the top it says lah who should receive irradiated blood product. So basically, the people who should receive irradiated blood products are those who had previous stem cell transplant. So especially all allograft, they will need it for life. Autograft, so their own stem cell transplant, will need it for about 3 months after their autograft lah. But some places just put them on lifelong irradiated blood product. Number 1. Number 2 are patients with Hodgkin's lymphoma, bukan non-Hodgkin's. So Hodgkin's lymphoma will need irradiated blood product throughout life. And the third group of patients are patients who had previous purine analog chemotherapy, such as fludarabine or cladribine, that sort of chemotherapy lah. And the reason for giving them irradiated blood product is because these patients are at a higher risk of graft versus host, transfusion-related graft versus host disease. And this is when the T lymphocytes in the transfusion, in the blood product, attacks your patient's tissues lah. And this can cause death. So quite bad lah. Tapi actually the incidence of this is very small, and the risk of it is very small if the patient is exposed to non-irradiated blood product. So it's not really, tapi you should really be giving them irradiated blood product for life lah. Tapi it's very small. The reason being sebab kita dah leukodeplete kan, so dah sebenarnya tak banyak pun T cells in the blood products. Okay, but these are the patients who should receive them. CMV negative. Do you guys know who should receive CMV negative blood? Neonates, pregnant women, previously immunosuppressed patients. Tapi I think the current guidance is they no longer need CMV negative blood lah. HBS negative, this is very important in some patients with sickle cell. So if you guys see any patients with sickle cell disease crisis and they need blood products, make sure you tell the lab that they have sickle cell and they need HBS negative. Okay, so but sickle cell patient patients with sickle cell trait, so they still have normal HbA and no sickle HBS. So they can also donate blood in. So you want to make sure that the blood that you're giving back to the patient is not HBS. Okay, and then also patients. So sometimes you can order washed blood red cells, especially if patients previously had sort of reaction, allergic reaction, multiple allergic reaction to blood products. So it can be washed, but this is very rare lah. Okay, we talked a bit about who gets what. I'm sure you guys are aware about universal donor. So for red cells, the universal donor is group O, can, because they don't contain any antigens. And FFP is the other way around because the plasma cells is so group AB, kan? But the plasma in group AB does not contain anti-A and anti-B. Okay. For platelets, it's a bit different for reasons I'm not going to go into, but the universal donor for platelets is A negative. But that's fine. Nanti kita boleh bincang lah kalau nak. Okay, so we're going to go into the meat of this. Okay, just a quick sort of scenario lah. I've got 3 patients in front of me. They are all anemic. So show a hand kot. Siapa yang nak transfuse? So who will transfuse which patient lah? So the first patient is 26-year-old female, 4 months of fatigue. Saw her GP and GP sent to acute medical unit. She's anemic with low MCV and found to be iron deficient. Would you transfuse this patient? Ada orang tu dalam chat tak? Ke ada siapa nak cakap? Siapa yang akan transfuse this patient? Boleh raise their hand. Okay, tak ada. Siapa? Fariha Reza akan. Okay. You will transfuse this patient, okay. Okay, that's fine. That's a clinical decision. Number 2, there's a patient who's 40-year-old. He has got type 1 diabetes for ages, okay, since he was 12, for example. So he ended up with ESRF as he would, and is currently on dialysis. Was found to have a hemoglobin of 63. Feels a bit fatigued, a bit short of breath. Would you transfuse this patient? Okay. Fariha angkat tangan tu sebab nak tanya soalan ke ataupun nak transfuse?
Saya tak lower hand lagi, sorry.
Okay.
Tadi tu.
Itulah, siapa yang akan transfuse this patient? Or Api nak transfuse this patient? Do you think he should be transfused? It's a bit out of breath.
I probably won't.
You probably won't. Okay. Okay, yeah, that's fine.
Because of end-stage renal failure, so I'm a bit conserved.
Okay. Yeah, okay. Number 3, 80-year-old patient with MDS. MDS is myelodysplastic syndrome, and that's basically a form of primary bone marrow failure. So when your bone marrow is not producing effective cells, again. So patients with MDS tends to be cytopenic lah. Previous and STEMI, mild shortness of breath on exertion, hemoglobin is 77. Would you transfuse this patient? Ada yang kata nak ataupun tak ke? Tak lah. I cannot see the chat box.
A bit 50-50 dengan dia sebab HB yang rendah tu could cause type 2 MI juga, given the, I don't know, mungkin tak related lah dengan previous STEMI tu, but he's quite at risk. Cuma I know nothing about transfusion in MDS, so I don't know.
Oh, okay. Yeah. I think out of the 3, he's probably the one that I would transfuse based on the information that's given. So you're right. Sebab he's high risk. You'd want to keep his hemoglobin up because you are exposing him to risk of cardiac ischemia, and then he's got MDS. So he's not gonna be able to so he needs external help, essentially. So you can either transfuse or you can give them EPO or whatever. Tapi itulah, so there's no right or wrong answer, okay, because it really is the decision to transfuse is very dependent on your clinical decision lah, kan? So you are the clinician seeing the patient, and it's not the job of a hematologist to tell you to transfuse or not to transfuse, kan? But the thing that you should be thinking about is risk versus benefit, as with any medical procedures or intervention that you are proposing to a patient, kan? So what are the can you guys rattle off some of the risks of transfusion if you are offering some of these people transfusion? Shafiq, Fatin, feel free to cakap.
Naim, actually kalau tengok dalam chat box, for two of your questions from the previous slide, Fatin answered them correctly lah. Patient with previous transplant and PEDS patient. Maybe just want to ask a question based on this. Regarding the irradiated blood, is it for only for those with bone marrow transplant or all transplant patients?
Only for those with bone marrow transplant. Sebab they have defective leukocytes.
All right, okay.
Not all transplant. Okay.
So in the chat box, Sarah has answered Charlie.
Charlie, okay. So Charlie, I would add all of the other transfusion related reaction lah. So that's a risk of transfusion again. And some people die from, so it's not, well, it's not a huge risk, but it is a risk kan. Lagi?
And Fatin kata Taco,
yeah, Taco and Charlie. the favorite thing to say lah during Viva. Lagi? So those are the transfusion reactions. Allergic reactions, yeah. So we're listing down the transfusion reactions. So you've got Taco, Charlie, allergic reactions. Lagi apa lagi risk of transfusion?
ABO incompatibility.
Yes. Lagi?
Bloodborne infection.
Bloodborne infection, yes. Nak tanya siapa yang siapa yang tak pernah prescribe blood products before? Angkat tangan. Mungkin yang kat PEDS kot. Kat PEDS pun kena kan prescribe. Tak tahu lah, dia bagi tak F1 kan prescribe. Tapi I just wanted to ask lah, when you prescribe blood product, siapa yang pernah consent patient? Oh, just prescribe je. And then nurse bagi kan. Pernah tak korang consent patient? And if you guys have, apa yang korang akan cakap masa consent tu? Interesting actually. Yeah, okay. So you guys have mentioned all of the transfusion reaction kan? And indeed, those are the kind of things that you would think about lah when you think about risk of transfusion kan? But there's also other things, and so transfusion reaction is the main thing that I wrote lah. But also there are other risks. So what are the risks? The other risk is as I mentioned earlier kan? If you give someone a transfusion, then you risk them developing antibodies against blood products, which may limit their future blood products need kan? May limit their the future blood products that they can have, because they can't have products with certain antigen kan? And it may delay their future transfusion, who knows kan? And this is especially important in two groups of people. First, women of childbearing age. But if you develop antibodies against, so IgG antibodies, these can cross the placenta, and it can actually cause neonatal hemolytic syndrome. So it can be quite significant. So that's why you don't want to transfuse people unnecessarily, number one. And number two, patients who may need transplant, macam Apip kata tadi kan. So like this man with ESRF, you would think about kidney transplant kan for him kan. So you don't want them to be developing antibodies which may complicate their future transplant. Okay. So that's why you are a bit cautious lah about transfusing these people kan. And then transmission of bloodborne infection, although this is very rare, sebab all of the blood products in the UK are screened for HIV, hepatitis C and hepatitis B, but it's still there kan, especially I don't know what the system is like in Malaysia lah, so it's something that you have to think about kan. Also people who have had transfusion are not going to be allowed to donate blood in the future. And that may be significant for certain groups of people kan, if they are altruistic and want to donate blood. And also you have to remember that some people just don't want transfusion kan, for example Jehovah's Witness, and this is something that you have to consider. Okay, so that's why, so when you think about risk versus benefits, so for example in some of these people, what I would be thinking about is what are the risks. So number 1 and 2, you probably think more about the risk of them producing or developing allo antibodies. So that therefore you want to avoid transfusion if you can. And also you have to think about why are they anemic kan? So this lady is anemic because she's iron deficient. So as soon as you replace the iron, hopefully she will get better. Her anemia will resolve. Kan? The same goes with this gentleman. Kan? He's anemic because of the kidney failure, doesn't produce enough EPO. So maybe we can try and treat with EPO first. Again, so this patient with MDS, sometimes you can treat MDS with EPO. Sometimes they don't respond very well. So patients with cancer, myelosuppressed and so on, they don't have any recourse, so they can't produce red cell anyway. So that's why sometimes they are just transfusion dependent. So that's fine. So patients with thalassemia, for example, just transfusion is dependent. So there's no way to avoid transfusion, if you see what I mean. So sorry, I'll try. Okay, think about alternative to transfusion. So make sure their hematinics and iron is fully replaced. I had a lady who's pregnant with hemoglobin of 40 something, very low folate. As soon as you replace the folate, the hemoglobin goes up. So so sometimes it's an easy fix lah. Think about erythropoietic agents like EPO. So this is the number 3 and number 4 is probably more useful in surgery lah. Think about options to cell salvage during the procedure. So you try and capture their blood loss and reinfuse. There's a way. I've never actually come across it. And also think about, so this is a program that may be available in certain tertiary center where if you are going to have surgery in a few months, then you donate blood and then they can use your blood to reinfuse. So it reduces your risk of problems lah, and because you are being reinfused your blood. Okay, so just a quick scenario: you are called to the cancer ward. So cancer ward is a very fertile center for blood products, and so all the hematology patients use blood product. So Mr. AF, 62-year-old, 15 minutes into his red cell transfusion when he developed a fever of 38.1. What would you guys do normally? Siapa yang pernah come across this scenario?
You will stop the transfusion first.
You will stop it immediately. And then what would you do once you stop it?
Do A to E assessment.
Yeah. Lagi?
Ensure antibiotics are prescribed paracetamol.
Antibiotics and paracetamol.
Paracetamol. I didn't say antibiotics.
Oh, okay. So you want to prescribe some paracetamol. That's a good suggestion. And then? If for example, afterwards he's fine, his fever settles, what would you do?
Restart the transfusion.
You can restart the transfusion. Okay. I'm sure in the real life setting, you guys would do more lah. Maksudnya you would look into the notes and see, because you have to remember that this is a cancer ward. A lot of the patients are neutropenic. Are they already on antibiotics? Do they need reculture? There's a lot of things to think about lah. And if the patient's neutropenic and they're not on antibiotics, you tend to want to cover anyway, but that's a clinical decision. But yeah, so this is a very common scenario again, and a lot of patients develop non-hemolytic febrile reaction, and a lot of the times you can just give some paracetamol. Sometimes if they develop allergic reaction, you can just give some antihistamine and then you can restart the transfusion afterwards lah. So it's a very common scenario lah. But I was hoping to use this brief to talk a bit about transfusion reaction. Kan? So when you think about transfusion reaction, you guys can think about it in, so divide it into either acute or delayed, and then immunologic or non-immunologic. Okay? Immunologic is when basically the product, either your body reacts to the product or the stuff in the product reacts to your body. And the main thing in the blood product that can react to your body is basically the T cells. And this is much less common because of what I said about leukodepletion. Kan? But what's more common is how your body reacts to the product lah. Yeah, so this is basically how you would classify it. You guys are probably going to be involved in more acute reactions. So immunologic, you can, so acute hemolytic transfusion reaction is probably the one that you don't want to come across, because it's usually just caused by ABO mismatch. Although you can have similar reaction to other groups that I was talking about earlier, but it's much less common, much more rare. The more common stuff that you come across would be allergic reaction, febrile, in which case you guys can just give treatment to the symptoms. So paracetamol for fever, antihistamines or chlorpheniramine for allergic reaction, monitor, and then you can restart at a slower infusion if you want. Okay. And then this is something that you see rarely lah, Trali. Trali is basically just ARDS, and it tends to occur like 3 to 4 hours after the transfusion. But it's something that you guys should be aware of lah. And treatment is basically how you treat ARDS with supportive treatment. Okay. I guess the main thing that is important to be aware of is TACO, so transfusion-associated circulatory overload. And this is something that you have to remember like in patients who are at a higher risk, cardiac disease and so on, and think about giving furosemide with your transfusion. You get the other, like bacterial contamination is a lot less common. And it's something that you have to, if you are suspecting it, definitely have a chat with the transfusion team or your transfusion lab. Sebab if you suspect that, they would have to culture the blood product, and then they would have to inform NHSBTs, but they would then have to hunt for the other blood products from the same donor and then test them as well. So it's a lot of hassle. Delayed reaction. So this is what you tend to get if you have developed antibodies against blood product, and then that antibody act or attack the product that you have transfused. And this tends to occur 24-48 hours afterward. Okay, because IgG antibody, they act on the red cell, and then this get consumed by your spleen. So this is something that you tend to see afterwards. So something that, so if you have someone who had been transfused a few days before and then suddenly come in with lower hemoglobin, then you want to make sure that they don't have a delayed transfusion reaction. So semua orang dah tahu benda ni, so I just go through it very quickly. This is an initiative from NHSBT a few years ago. Basically, prescribe 1 unit at a time, and then review after every unit to make sure that the patient doesn't go into circulatory overload basically. Although this is very poorly adhered to in some places, especially in hematology, sebab patients tend to get 2-3 units straight away sebab tapi it's something that you have to bear in mind okay. Okay, these are the key points. The main thing I would say as an F1 is or junior doctors on the ward, definitely think about risk and benefits of transfusion to the patient. And if you haven't done already, every patient that you want to prescribe transfusion or blood products to, you have to tell them about the risk maksudnya consent them as you would any other treatment. And also anticipate the need for transfusion early, especially in patients that you expect that they would have a higher risk of developing antibodies. For example, sickle cell patient sometimes sickle cell patients, if they require exchange transfusion, so they come in crisis. Siapa yang kerja kat London, lagi banyak lah sickle. I don't know, in Nottingham, do you see a lot of sickle? I don't know. So basically, if they come in crisis and they need exchange transfusion, they need their whole blood volume replaced by another red cell. So they would need like 7-8 units each exchange. And you want to be able to see if they've got antibodies early. So if you need transfusion in 2 days' time, then we've got all the, so you don't want to be transfusing now and then send group and screen now, but you will find out, oh, actually we need more time to look for these antibodies. So yeah, so that's the problem. So make sure you anticipate okay. Okay, that's about transfusion. Kalau ada any questions, boleh fire lah. I thought I'd go briefly to different sort of diagnostics and different stuff that we get asked a lot lah. So firstly, blood count. I'm sure you guys have been in contact with the local hematologist about cytopenia, cytosis, what do we do next, and so on so I thought I explain ataupun cerita sikit lah how do we normally approach blood count abnormalities and the kind of thing that we think about when we do screen for a few things so this is the most important picture that I have in mind when I think about your blood count. So this is what actually happened. So this is your picture of hematopoiesis. All of your terminal blood cells originate from a single stem cell that has the potential to become any of these cells, can. And they usually quite early on divide into these two groups. Okay, they can either go into myeloid lineage or lymphoid lineage. And these lymphoid lineage are so your myeloid lineage. So the stem cells differentiate into common myeloid progenitor, and these can then differentiate into your megakaryocytes, which then become your platelets. They can differentiate into your granulocytes and monocytes, and they become your myeloid red cells, myeloid white cells, so basophils, neutrophils, eosinophils, and monocytes. And they can also differentiate into your erythrocytes, so red cell can. So these are all your myeloid. So when we talk about CML, myeloproliferative disorder, it's a problem with this lineage. And then you have a separate lineage, which mostly, so this is your lymphoid lineage. So your stem cell differentiate into a common lymphoid progenitor, and these normally go into your thymus or your lymph node and mature there, and they become your lymphocytes, and your B lymphocytes then become your plasma cells. Okay, so when you think about, so for example, if you have anemia, so less erythrocyte, then the problem is going to be either here or somewhere else lah. Tapi this is a very good way of looking at your blood cells lah. And that's why sometimes with if you think about it, if you have anemia, iron deficiency anemia, sometimes you get thrombocytosis. Why? Because this is activated even more, and so you produce more thrombocytes because your body is trying to replace your red cells, but it can't because it doesn't have an iron. Okay, so it makes sense lah when you think about it this way, kan? And then the other part is your reticuloendothelial system. So this is the system that actually recycles your blood cells. So this is actually basically the system of your macrophages in various different organs, and they help phagocytose infection, ataupun bacteria and so on. But the other thing that they do, especially your spleen and your liver, they also recycle your blood cell. So your blood cells are produced in the bone marrow. Lymphoid cells are mature in the lymph nodes, and they get destroyed in the spleen. Okay, so that's your life cycle of your cells lah. So when you think about cytopenias and cytopenias and cytosis, so if we talk about cytopenias, I normally try and categorize the issues into either problems with production, problem with destruction or consumption, and benign causes that's not related with either. Okay, and this can roughly be applied to any of the cell lineages lah. Although this is not very accurate, tapi when you think about, okay, why is this patient anemic? Is it because there's a problem with production of red cells or problem with consumption of red cells? Kan? Why is this person anemic and thrombocytopenic? Is it problem with production or consumption? That's how you think about it. Okay, I'm going to start with benign causes. Okay, sometimes there's just a problem with how the automated cell counter in the lab counts the cells. Kan? And this is I don't know if you guys have seen spurious thrombocytopenia. Nothing. And then when you look at the blood film comment, it says, oh, there's a platelet clump. And so that is something that occurs very commonly lah, when you put blood cell you put your blood in the EDTA tube, the purple tube. Sometimes whatever it is in the EDTA can cause the platelet to clump together. And as a result, the counter doesn't count these platelets as platelets. They count it as something else. So that's why you get a spuriously low platelet count when in fact actually the level is normal. And so there's a way around it, in which case you send the blood test in a citrated tube or in a different tube lah, to counteract that problem lah. Tapi that is artifactual lah. Maksudnya you're not actually thrombocytopenic. It's just the fact that it's just because of that lah. And some patients, for example, that's delusional. So you have to think about whether when you get spurious result, whether you're taking it from the drip arm, for example. And also, especially with neutropenia, certain ethnic groups are more susceptible to becoming neutropenic when it's normal for them. For example, Afro-Caribbean people. Okay. So those are the benign causes which you have to sort of think about before you jump into any of these other causes. But if you think about these other causes, for example, if the patient's anemic, is it because their bone marrow is not working very well? Either because they're taking medications that suppress their bone marrow, they had chemotherapy, for example, or there's just a primary problem with their bone marrow. They've got MDS, for example. Again, is it because the marrow is infiltrated by cancer cells? Either it's hematological cancer or something else, like bony mets from prostate cancer, for example. Again, or is it because they can't produce the cells because they don't have the right substrate? So this is especially with anemia, and they don't have iron. They've got renal failure, so they don't produce EPO. So they don't have the hormone that pushes their bone marrow to produce the cells. Liver patients, with thrombocytopenia, they don't produce TPO, which is produced in the liver. So that's why they are thrombocytopenic, for example, again. Or they are B12 or folate deficiency, again. So when you think about cytopenias, think about these, and before you make a call to the hematologist, if you want to impress them, you have already started doing these investigations beforehand, again. So sometimes myeloma is a form of infiltration, and that can cause production issues. Okay, so that's one end. If it's not problem with production, is it a problem with consumption? The blood cells being destroyed peripherally again. For example, if they've got hemolytic anemia, hemolysis, or low platelet caused by splenomegaly kan. So liver patients, again, tengok kat apik kan. Liver patients have got cirrhosis, portal hypertension, big spleen, and that cause low platelet kan, sebab their platelets are being sequestered. Or are they bleeding and are they bleeding out, and therefore they are consumed, well, they are losing their blood lah. Okay, so this is a nice way to look at it, I think. And then I had a few slides. So I had a few slides with specific things that you think about in anemia or thrombocytopenia or leukopenia. But I'm not going to go into this because this is a bit more in-depth lah. So that's cytopenias. And then I appreciate I have like 5 minutes. So I'm going to try and do this very quickly. So cytosis, again, you think about whether the cause is primary or secondary. So primary is your bone marrow problem. And this is when you ask the hematologist whether they would consider doing a bone marrow assessment, biopsy, or whether they would consider doing further tests lah. So as I said before, again, so if you've got a problem with this, so you've got lymphocytosis, then is it a lymphoproliferative disorder? Or if you have erythrocytosis and thrombocytosis, is it a myeloproliferative disorder? Okay, and these are examples of MPN, and lymphoproliferative disorders are your lymphoma lah. Okay, B T cell disorder lah. And then, but you always think about secondary causes first lah. So what can cause your bone marrow to overproduce your cells? Infection, inflammation, erythrocytosis. So if you are chronically hypoxic, people with OSA on CPAP, people who live in high altitude, so they would produce more EPO and to try and counteract their hypoxia. So they are going to be having higher red cell count. Some people have EPO producing tumor, especially in the kidneys or in the brain. So some people are just dehydrated. So that's actually artifactual lah sebenarnya kan. Thrombocytosis can be caused by iron deficiency. So think about that. And things like smoking and like allergic reaction can cause increase in the number of your eosinophil, neutrophil, and so on. Okay, so that's briefly about how you would approach blood count abnormalities. And then I thought I'd go just very briefly about myeloma screen. Have you guys ever been asked by your consultants or registrars or yourself, you just want to send a myeloma screen? What would you send? When you say myeloma screen, what would you actually do? Siapa tahu?
So Sarah ada jawab sikit. Serum IG, serum immunoglobulins, urine, Bence-Jones protein.
Ooh, okay. Serum immunoglobulins and Bence-Jones proteins. Okay. Right line, tapi not accurate. Okay. Ada lagi tak? Any other takers? Anything else? Okay. Okay, I'm just going to move on, okay? Tapi betul, yeah, that's what you're looking at, but what you're sending is actually different. You're sending serum electrophoresis. That's right. So before we talk about myeloma screen, I just want to talk a bit about myeloma. What is myeloma? Myeloma is a cancer of the plasma cells, and this is what they look like under the microscope. Bone marrow, very, very nice, beautiful cells. One of my favorite cells lah on the bone marrow again. So myeloma is a cancer of the plasma cells. So plasma cells are cells that mature B cells. So B cells mature into plasma cells, and these produce antibodies, kan? So antibodies exist in this form. So if you remember from your medical school, your antibody contains your heavy chains and your light chains. And your heavy chain, in the variable region, there are 5 different isotypes. So you've got IgM, IgA, IgG, IgE, and IgD. And then your light chains, you've got 2 different isotypes, your kappa and lambda. Okay, so what you're looking at is, so normal plasma cells produce different types of antibodies. So they've got, so you see polyclonal light chains and polyclonal immunoglobulins. So you see the same sort of proportion of your IgA, IgM, IgG, IgE again. So what you're looking for when you screen for myeloma is you're looking for a monoclonal proliferation of antibodies. Okay, so you're looking at one specific subtype of paraprotein. Okay, and this is when you send serum electrophoresis, sometimes you see normal again. Sometimes you see polyclonal increase in gamma region, which means that there is an infection or inflammation somewhere where your plasma cells are just produced in a large amount, and these plasma cells are not from one clonal population. So there's no genetic mutation that's causing these plasma cells to proliferate. So these are just plasma cells that your body produce in reaction to the infection, and these produce different types of plasma light chains and antibodies. Kan? In myeloma, you have one clone yang mutated, and this clone produce a lot of the same clone, and these produce the same number or same amount and same type of antibodies. So this is when you do a myeloma serum electrophoresis, you see there is an IgG kappa paraprotein. So all of these cells are producing IgG kappa light chain. So IgG kappa paraprotein. So that is the monoclonal bit. So that's what you are interested in, is essentially lah. Okay. So when you do a myeloma screen, what you want to this is just a slide explaining what myeloma is. So it's a cancer of the plasma cells, and the sequelae of myeloma is you get anemia, so CRAP, if you remember, so hypercalcemia, anemia, renal dysfunction, and bony disease. So when you do a myeloma screen, what you want to do, perhaps you wouldn't go into skeletal survey, but what you want to do is you want to do the serum electrophoresis and free light chains, but you also want to do calcium, renal function, and full blood count to look for anemia again. Okay, and then you can do your bone marrow, but that's the hematologist punya role lah. Tapi that's what you want to do lah when you ask for a myeloma screen on top of your serum electrophoresis and free light chains. So what is serum electrophoresis? If I just briefly explain this. So serum from medical school lah. Serum electrophoresis is when you put your plasma, so plasma contains all of your antibodies, and put your plasma into this gel, and then you run a electrical circuit. You run an electrical current across the gel. Tapi minta masa sikit kan, dah 91 minit, tapi just nak finish a few things lah. You run an electrical current across, and depending on the size of the protein and the charge on the protein, it will migrate to different region, and it will settle into one of these regions lah. So what you're looking for is a band where there's a higher number, and that's your paraprotein lah. So that's why. So what you're asking for is not just the number of immunoglobulins, but you're looking for this specific band of paraprotein. Okay, that's why you're asking for serum electrophoresis. Immunofixation is when you're trying to see so this band contains everything, and so you're trying to see what does this band contain. Is it just IgG, IgA, or IgM? So if you look at this picture, there's a lot of IgG and a lot of kappa, kan? So IgG, there's a monoclonal increase in IgG kappa, which makes you suspicious of myeloma. Okay. And this is what like the picture looks like now. So for example, in multiple myeloma, you see one single sharp rise of the same type of protein, and whereas in acute inflammation, you see different types. Okay, nampak? Okay, so in short, myeloma screen, you want to send serum electrophoresis, you want to send free light chains, okay? Because sometimes if these are produced in excess, your body, the myeloma cells also produce the light chain on its own without being attached to the heavy chain, which makes your IG lah. So you want to send that as well. So what's urine's Benz-Jones? Urine. What is the urine Benz-Jones proteins? So these are actually the light chains that are excreted in your kidney, in the urine. So serum free light chains basically supersedes urinary Benz-Jones protein. So we don't really send Benz-Jones proteins anymore. We do if we have very low suspicion of myeloma, and because sometimes when you do free light chains, you get increase, but that's because of their inflammation or whatever. So you can do urinary Benz-Jones protein if you want to detect a monoclonal free light chain. Okay, I hope that makes sense lah. Minta maaf lah macam dah nan sikit. Okay, I will just showing some examples lah. In this example, the first patient has myeloma because there is a IgG kappa band detected with a paraprotein of 32 grams per liter. So that's myeloma. And this other patient also has bony pain, but serum electrophoresis does not detect any paraprotein, and there is a polyclonal increase in the immunoglobulins. So this person doesn't have myeloma. We're not concerned. Okay, and you can see that the kappa and lambda ratio is raised, but that's because the person has got end-stage renal failure. And you can see that both kappa and lambda is raised, so it's polyclonal rather than monoclonal. I hope that makes sense, Ken. Okay, a bit about iron profile. So when you interpret iron profile, you look at three things. You look at their ferritin, you look at their transferrin, and you look at their transferrin saturation. I never look at serum iron because serum iron varies widely depending on the time of the day, and it's not very reliable. Ferritin, low ferritin definitely confirms iron deficiency. If you have someone with low ferritin, it's iron deficiency, basically. Even if they're not anemic, they are low in iron, so you would consider replacing it. But also remember, ferritin is an acute phase reactant, so it can be elevated. So having a high ferritin does not exclude iron deficiency. So if you have high ferritin and you are concerned that the patient might be iron deficient, the other way we can have a look at it is by looking at their transferrin and transferrin saturation. So transferrin is a surrogate for total iron binding capacity. Transferrin saturation is a marker of how many of your transferrin is saturated with iron. So if your transferrin saturation is low, it will be high in iron overload. If it's low, i.e. less than 15%, then it could be iron deficiency, or it could be an absolute iron deficiency, or it could be a functional iron deficiency from chronic inflammation. When I say functional iron deficiency, it means that because of chronic inflammation, your body cannot use the iron to make red cell. Okay, so replacing iron wouldn't be useful because your body cannot use it anyways. The way that you can try and figure out whether this is chronic inflammation or iron deficiency is by looking at the transferrin. Okay, transferrin is a protein that your liver produces to transport iron. So if your transferrin is high with low transferrin saturation, that is typically more consistent with iron deficiency. Okay, so but your body is trying to produce more transferrin to help carry this iron around. If your transferrin is low, in the context of low transferrin saturation, it is more likely to be chronic inflammation related. Does that make sense? Okay, so you look at both of them together. And you have to remember, transferrin can be low in inflammation. It can be low in liver cirrhosis because your liver cannot produce transferrin. The other thing I just thought I talk about with iron metabolism is you have to remember, iron, your body does not have a mechanism to excrete iron from the body. Okay, so your iron, so what happens is the main source of your iron from your body in your body is from your diet. and also from recycling of your red cells. Okay, that's why if you have someone with iron deficiency anemia, what are you concerned about in elderly? You are concerned that there might be bleeding somewhere because their body cannot recycle that red cells, okay, because they are losing the red cells, kan? So that's why they become iron deficient. So they might be bleeding from their gut, they might be bleeding from wherever lah. So that's why you are concerned lah. So the main thing to remember is the iron is mostly absorbed in the gut. It can be absorbed as a heme iron or non-heme iron. So heme iron is contained in meats, and non-heme iron is contained in like grains and vegetables and that kind of stuff lah. That's why people who are vegetarian, so heme iron is easily absorbed compared to non-heme iron. So people who are vegetarian are more likely to be iron deficient. Number one. Number two, non-heme iron exists in either ferric or ferrous type, and the type that is absorbed is ferrous. So things that help convert ferric to ferrous is vitamin C. So you always ask your patient to take iron supplements with vitamin C containing juice, such as orange juice, lemon, and so on. Okay, and things like taxanes, so tea, coffee, inhibit iron absorption. So you avoid, tell your patient not to take the iron with tea or coffee. Number one, okay. Oh yeah, that's the main thing lah. The other thing is, one of the things that help iron being absorbed is this ferroportin. So ferroportin transports iron from your gut cells to the bloodstream. Okay, and recently there's this new protein that has been found, which is called hepcidin. Hepcidin is a protein that is produced by the liver, and it is increased in inflammation. Okay, and what hepcidin does is it stops ferroportin from transporting iron into your bloodstream. So hepcidin acts like a gatekeeper, and that stops iron from being absorbed. Okay, so what this means is, so your level of hepcidin increases when you take iron. So there's a new way in which we ask patients to take iron supplements. So previously, we tend to prescribe irons like ferrous sulfate or ferrous fumarate 3 times a day, kan? But what we found with hepcidin, it's not efficient to take iron that way, because so when you take iron the first thing in the morning, your next iron is not going to be, it's going to be less absorbed. Okay, so nowadays we tend to say to our patient, either take iron once a day or every other day, because it is as efficacious. And as you, if you guys ever take iron, siapa-siapa yang pernah pregnant kan, I pernah makan lah iron, my wife punya iron tablets kan. Iron is very, there's a lot of side effects. It makes your tummy feel very bad. And so you improve compliance without diminishing efficacy. Okay, I hope that is useful lah, because that's something that I haven't known before lah. Okay, that's it. Okay, I'm not going to talk about hemolysis cream. Sorry, way overran. It's 10 past. But I'm happy to take any questions. Okay, I'm very bad at keeping to time kan. Tapi I hope this has been useful lah. Yeah, any questions? Siapa-siapa nak cakap?
Thank you very much, Naim, for the amazing presentation and teaching. I'm just going to ask some questions which are currently in the chat box. So question number 1 from Sarah. She was asking, should we stop sending urine BJP then? Or does it still have any clinical use nowadays? Or is it obsolete?
It's largely been superseded by free light chains, because it basically tests the same thing. The time that I would send a urinary Benz-Jones protein is in low risk patients, so patient yang ada autoimmune condition or whatever kan, and you expect if you send serum free light chain, it's going to be high sebab they have got autoimmune condition. So sending a urinary Benz-Jones protein would help me, it would help so because it will tell me if the high serum free light chain is from a monoclonal light chain. So it would so because it detects monoclonal light chain in the urine.
Mhm.
Okay. So it's useful for screening too lah. In someone that I am not really concerned about myeloma, but I wanted to exclude light chain monoclonality. Does that make sense?
Okay, so will it be useful as a screening tool, let's say in a GP setting where they cannot afford to have all these fancy tests done within seconds?
Well, it's not going to be seconds anyway, because
Yeah,
it
of
has
course,
to be
yeah.
sent. I think it's useful as a screening test, the Benz-Jones protein.
Okay.
But in general, for like workup for myeloma, we don't tend to use it anymore. We tend to use the serum-free light chains, because sometimes you can get light chain myeloma, where there's not a lot of paraprotein, just produce a lot of light chains. So if I am concerned about myeloma, like that's the clinical question, then I would actually send serum-free light chains rather than just urinary Benz-Jones protein. But if I'm doing it as screening, for example, if I see someone with pancytopenia, for example, again, and you're not really concerned about myeloma, but it's part of your screening tool, then you might consider Benz-Jones rather than free light chains.
So would it be fair to say that if you have high suspicion, go for serum-free light chains, whereas if you have low suspicion, you can go for urinary Benz-Jones protein?
Boleh? Okay, ada soalan lain?
Okay, thank you. Another question from Sarah as well. This is the question before that, asking about the pre-operative autologous donor. Do you know if where is it available in the UK?
I'm not sure. It's something that I came across before. I'm sure the people in surgery knows more about it. Tak tahu lah. I'm not sure. Sorry.
Okay.
I don't think Oxford has it even, where I work. So mana entah tadi? Pre-auto, yeah. I think it's probably something that is more common in the US kot. Or something that would be available to Jehovah's Witnesses.
Oh, right.
Hmm.
Because they basically they will be transfused with their own blood. So okay, so it's more acceptable that way.
Yeah.
Yeah. Sarah tanya juga, betul kan iron tablets are ideally taken with citric juice, orange juice to increase absorption? Yeah, I think this is what Naim has told us earlier. One of the strategy is to take it with the orange juice, lime juice.
Yeah, sebab vitamin C activates is a cofactor for ferric reductase. So it converts ferric to ferrous, and ferrous is the one that is absorbed into the enterocytes. If you read about iron metabolism, it's very fascinating sebenarnya. Menarik.
Okay. Any more questions from the audience?
Oh, the other thing I was going to mention, you know, iron is not, so why people get iron overload. Sebab you don't have any mechanism to remove iron from your body. Okay, the way that you remove iron is via your bile duct kan. So once your body recycle your red cell, it gets broken down into hemoglobin and hemoglobin gets broken down into globin and heme, kan? And then that heme is excreted as part of your bile, and then it just gets reabsorbed, kan? So that's how your body regulates iron. So people with hemochromatosis have got a problem with the fact that they keep accumulating iron without any, because it doesn't get excreted in your urine ke apa ke. So that's why these people, the way to remove iron from their body is by vivisecting. I found that interesting lah. Okay, ada soalan lain ke? Sorry if it's a bit rushed. Hopefully I've given you a good overview lah of what our day-to-day life and questions are normally.
Can I just ask you one question? Oh, sorry. Yeah, Shafiq. Go,
Oh,
go.
okay. Oh, tak, just not to clarify about the iron that you mentioned that you ask the patient to take iron supplement about once daily or every other day. Is it I don't know, is it the same with the BNF, or is it something that has been practiced?
I think this is born out because this hepcidin is very recent, very recent meaning like in the last 10 years. And what we have found is that when you take iron, your body detects it, and it increases the number of hepcidin that your liver produces, and that acts as a gatekeeper to stop further iron from being absorbed. So if you give someone, so for example, if someone has been taking, so if you give someone iron 3 times a day, the first tablet that day they will absorb okay, and then the second tablet is not going to be as the absorption is not going to be as good as the first one. So you actually have diminishing returns. So what we have found nowadays is that once daily prescription is as efficacious as 3 times a day prescription. Increasing the number of iron that you take a day doesn't really increase the absorption, or doesn't increase the amount of iron that you get. And it's much better for the patient because it increases compliance.
Okay, thank you.
Sorry, I feel this one.
Yeah. Just a quick question. You mentioned about DIC at the beginning of your presentation. I'm wondering if DIC is actually a condition that needs to be treated per se, or whether it is just a manifestation of underlying disease that instead of the focus is on to treating the DIC, you should treat the underlying problems.
You definitely should treat the underlying problem. I wonder if everyone is aware, kan, DIC itu apa? Disseminated intravascular coagulation. Basically, what you have is you have activation or overactivation of your coagulation cascade, and therefore your body consumes all of the clotting factors, and therefore, so you get widespread thrombosis, which manifests these petechiae, and then you also get because your clotting factors are being consumed, you get bleeding. Okay. So treatment is by treatment of the underlying condition. So whether that's cancer or infection or whatever, but also you have to think about this patient is bleeding with low clotting. So you have to support them. So sometimes you do have to give them FFP or platelets or whatever, depending on what their clinical state is lah. Bearing in mind that the whatever factor they are going to give, if you don't treat the underlying condition, you are just going to be consuming it again lah. Sebab the underlying condition is not treated. Does that make sense? Oh, one thing about platelets, I have always been asked about, so I don't know how it works in your hospital lah, tapi in my hospital, platelets have to be authorized by hematologists. So macam penat sikit lah nak kena authorize platelets kan. Tapi it's very important lah, platelets, especially in condition where like inflammation and so on, they consume your platelets. So if you want to give someone platelet, for example, if you want to do an operation where you want the platelet to be above 50 kan, so you want to be giving them platelet just before the procedure, so like an hour before. So that's the highest number of platelet that you get lah. So that's the least risk of bleeding lah. Because afterwards your platelets just gonna be dropping lah. So bearing that in mind. Okay. Ada lagi?
Okay. Any more questions from the audience? No, nothing else. Okay. So thank you very much, Naeem, for the presentations this month and last month as well. It has been a pleasure to have quite extensive and detailed teaching on hematology. I'm sure the audience finds them useful as well.
Thank you.
Okay, so before we close our session today, please kindly use the link that I have provided to provide some feedbacks for Naeem and his e-portfolio.
Terima kasih semua.
And of course, if you guys want to present anything at all, I think by now, maybe some of you have already had some ideas about audit, and maybe you have already started with your audit as well. And if you would like to present to us to obtain some feedbacks, then please do contact any of the mentors in the Buddies group. Okay. Okay, kalau tak ada apa lagi, kita boleh tutup lah kot dengan tasbih kafarah dan suratul As. Okay, Assalamualaikum warahmatullahi and good evening and have a good rest, everyone.
Terima kasih.
Waalaikumsalam. Thank you, Naeem.